So although the time shows 20 minutes, but I'm just going to take about less than 5 minutes to, just put forth. I'm just going to give an overview of what is the global prevalence of testosterone deficiency and hypogonadism, particularly in the context of diabetes. So as has been highlighted that, this is a problem which is something which needs to be recognized, and the prevalence estimates also vary depending on how it is defined, and whether you are looking at symptoms or just looking at biochemical parameters. And one important point that only brought in the presentation just now was about the repeat testing, the fact that you need to find a persistently low level. That is the point that needs to be emphasized. And so therefore, if you look at which population you're studying, what are the criteria you're using for diagnosis of testosterone deficiency, and whether you're looking at only symptoms or whether you're looking at biochemical parameters, you may have different prevalence rates. And what we have data from across the globe is that we have seen prevalence rates ranging from as low as 2% to as high as 30%, and these obviously vary with the age of the individual, and also the presence of other comorbidities, and also the thresholds that have been used in different studies across the literature. That if you look at all the studies, you find some studies looking at 300 as a cutoff, some studies looking at lower cutoffs of 250. So I think that is another parameter that has to be kept in mind when we are looking at the data from all these studies. And whether you're looking at population-based studies or clinic-based studies, because again, obviously there's going to be difference between population-based studies versus clinic-based studies. Are individuals who are coming to the clinic for some issue, and therefore this is going to have an impact on the estimation that you're going to do. And so we are again seeing that the prevalence rate in a HM study of a reported accrued prevalence of 38.7 using a higher cutoff of 300, and this was enrolling men more than 45 years of age. When you look at the European male aging study, they looked at the late onset hypogonadism, and they found a prevalence of 13.8% in the population. Now, if you're looking at so these are the issues that we have to keep in mind, and these are the prevalence rates that have been seen, and across different populations, you have this variability in terms of the prevalence rates that you have seen. And if you look at certain individuals with comorbidities, like if you're looking at men with obesity, metabolic syndrome, or type 2 diabetes, the prevalence rates obviously have been reported to be higher. And when you're looking at again, there could be regional differences in terms of prevalence rates. And also when you're using whether you're using total testosterone or whether you're using free testosterone, again there are issues in terms of measuring the free testosterone also, and the type of assay that is used also becomes very important, because if you're using the chemiluminescence assays, those are not very sort of good in terms of measuring the free testosterone, and then you need to have a equilibrium dialysis to separate out the free testosterone from the bound testosterone. And now if you're looking at more recent studies, we're looking at those which are done on the better estimations done on mass spectroscopy, and so those become much better. So if you have, but those facilities are not available across all the centers, and where you are using that, then you have much better. I mean, the prevalence rates probably may go down if you're looking at that. Now, so I've just discussed these points that the reasons for the variability are also one more aspect that was not discussed was the timing of blood sample that is collected. So if you look at the if you need to have consistency, then we need to look at collecting the sample early in the morning, then when the testosterone levels are at the highest. And so I think the other points have been discussed earlier. I've just discussed them in the earlier section. And so therefore, what we need to do is, when you're interpreting these prevalence data, we should look at it in the context of how we have defined the testosterone deficiency, what is the population that has been studied, the presence and absence of comorbidities. All these things have to be looked into, given consideration. And also we also need to look at the way the assay was performed. So these are, I think, important points that we should keep in mind. So with that, I'll open the house for further discussions. We'll have the other two presentations, and then we'll have some time for discussion where all the everybody could put in their questions and their viewpoints, and then we can take up the questions that have been designed by Dr. Hitesh. So thank